So I'm going to focus on a little bit of, as I said, repetitive talk about some of the causes of pancreatitis and also what we have to offer and what topics might arise when you see us from the medical side. You hear people talk about GI. Not all GI is lumped together, and so we're on the GI medical side of things, whereas Dr. Morgan, Dr. Adams, and the rest of the surgeons are on the GI surgery side of things. So it's sort of a distinction, and most everything that we do, medical therapy, of course, but also what we do from an intervention standpoint is really anything that can be done through an endoscope, through a flexible scope that passes through the mouth. One of the first organizations, I think, that comes to people's mind that do what we do is the National Pancreas Foundation. I want to highlight that for sure and thank them for their support of this for sure. And I put the website address. I'm sure there's a lot of information around, but wonderful information for clinicians, for your doctors at home, for you. There's a nice frequently asked questions section. You know, there are blogs. There's just a tremendous resource for patients with pancreas problems, and I would encourage you to delve into that a bit if you have an interest. So again, we need to know what we're talking about before we discuss it too much, but the definition of pancreatitis is really a combination of these things. One is pain, and we just heard in a very nice discussion about the description of pain and some of the things that cause it, but there's a very stereotypical pain that people get in their upper abdomen. Radiation in the back is sort of the classic description of that. And we think that almost everybody has that, but certainly there are patients that have pancreatitis or pancreas problems that pain may be in the sort of a secondary complaint, and maybe it's mostly nausea or whatnot, but most people will have that stereotypical pain. And then not only pain, but we also require some objective abnormalities in order to define a pancreatitis attack. And that usually is in the form of blood work, a blood test. I'm sure if you're here, you're familiar with what an amylase or a lipase value is. And sometimes those can be elevated mildly for any number of reasons. If someone has a protracted episode of vomiting, if they're ulcer disease, there are a number of things that can cause those blood tests to be elevated. But we generally look for a certain value, about 3 times the normal value, in order to call it pancreatitis. And the other thing that we see, sometimes we see both of them, sometimes we only see radiographic abnormalities. And the X-ray abnormalities are the things that really come into play for patients with chronic pancreatitis, because at some point the patients with chronic pancreatitis will eventually probably stop mounting an amylase or a lipase lab value that can be tested, and that's where some of the other non-blood work testing comes in, like a CAT scan or an MRI. And by definition, practically, if you see stones, calcifications, stones within the pancreas, then you can be pretty certain that what you're dealing with is chronic pancreatitis. This just emphasizes the time course that the pancreas enzymes can sometimes take. And I think the important thing to recognize is that sometimes people wonder, well, it feels like an attack, but why are my enzymes normal? And one of those reasons can be that it's not your pancreas, certainly, and not all pain that occurs in this box is pancreas pain. One of the other possibilities is that maybe the blood work is tested too early, particularly you see the lipase will lag behind the amylase test sometimes. And so sometimes if only one of those are checked, you can miss this. And also if it's checked sort of after, when the symptoms start getting better, as you can see on the back side of this, the amylase value tends to normalize or come down to normal sooner than the lipase test does. And so those are I think something to think about for people that have, at least certainly that we think about, for people that have attacks of what seem like pancreatitis, but their lab tests are normal, at least when they're checked. We've talked about this a bit, but I think it also bears repeating so that you sort of know structurally what we're dealing with. What's the business part of the pancreas? And This is it's really two functions. There's the part of the pancreas that makes the juice, makes the stuff that gets into your intestines and does the work on the food that you eat. As I tell patients, it really is what keeps you from ingesting a hamburger and seeing it come out the other end. And so this really is what breaks down your food. It helps you get the nutrients. But there's also a sort of a street sweeper function, or a plumbing function of the duct that also can be relevant in pancreas disease. And these two things work in concert. If you get enzymes into the duct but you can't get them out, then that's going to be a major problem and a major precipitant of pancreatitis. By no means do you need to know all these, but I just want to highlight the whole host of etiologies or causes of chronic pancreatitis. And I think a lot of lay people, for sure, a lot of people in the medical community as well, think chronic pancreatitis is a disease driven by alcohol. And as we've learned here and in some of our research with other centers around the country, particularly University of Pittsburgh, we've published some data on this that it's becoming more apparent that alcohol is perhaps a minority of patients with chronic pancreatitis. And so there are a whole host of causes, ranging from some of the more common ones, pancreas divisum we talked about, sphincter vodi I'll touch on in just a little bit. Autoimmune pancreatitis, you might see things talked about that. Pretty uncommon, but it's a potential cause. Genetic things, these things are certainly relevant. And probably the most relevant one of these is, you don't need to remember the name, but it's one of the more common causes of hereditary pancreatitis, or pancreatitis that's passed down through generations. And that one has particular relevance because there's such a high incidence of those patients also developing pancreatic cancer. And so that's one that we would want to know about, because we very well may treat that differently. Maybe we suggest a surgical approach much sooner than we would with some of the other diseases. Again, just another slide about some of the inherited causes. Don't need to worry too much about those. Maybe this one may bear a bit repeating. We think of cystic fibrosis as a lung disease. Little kids, they're malnourished, they've had breathing problems, died at a young age. But we think that perhaps some sort of cystic fibrosis-like abnormality, sort of for lack of a better term, a mild version of cystic fibrosis, very frequently can present with chronic pancreatitis and be at least one of the causes of chronic pancreatitis. Without lung disease, that is, or with very, very mild lung disease. So we've talked about what it is and how do we treat it. From the non-surgeon side, from the doctors, the medical doctor side, I always warn patients that it requires a lot of patience. It seems like we're really not doing anything because it's, in the best case scenario, it's pretty boring treatment if all goes well. And really two factors, or potentially three, but probably one of the more important ones is hydration. How exciting is getting IV fluid? Not very but that plays a very critical role particularly in the acute phase of pancreatitis, I should say. The other thing is that we don't let you eat. And I always tell patients that we're not punishing you. We don't think that you brought this on yourself, but it's a reflex. And food goes in, food passes by the pancreas and the intestine, and the reflex is the pancreas wants to make juice. And so the best way to combat that is to not put food there. And so that's the rationale behind what we refer to as bowel rest, or NPO, sort of the medical lingo for not letting you eat. And then endoscopic therapy, we'll talk a little bit about some other non-surgical therapies as well. So fluid resuscitation, fluids, how do we give it? And it's critical when people go in that we give fluid, give a lot of fluid and give it very early. And as I said, it seems like a very simple treatment. But you look at some of the medical data that would suggest, what does giving that fluid do? It keeps people from dying, gets people out of the hospital sooner, reduces the risk of being in the intensive care unit, reduces the risk of other bad things happening. Even though it seems like a very simple treatment, has a major role in the early treatment of pancreatitis. A few more words about nutrition. I think traditionally we've probably not fed people early enough or aggressively enough. Sometimes people will wait until blood values go back to normal. Really not necessary. If it looks like a mild bout of pancreatitis, then we tend to let people eat pretty early, and their pain comes back, and you know that it's too early. Other thing that we look for, if someone starts letting the pancreatitis patient eat and they start having fevers or some progressively abnormal blood tests like a white cell count, which is a measure of inflammation, then we know it's also too soon to let those people start eating. Oftentimes, if people have very protracted bouts of pancreatitis or just can't seem to get better when they're in the hospital, then we're looking at doing something other than food by mouth. Sometimes you can eat if you've got pancreatitis. Sometimes, because of the reflex I mentioned, your doctors don't want you to eat. So what are our options then? One is, you may have heard the term TPN, or total parenteral nutrition. That's essentially the big milky looking bag of fluid that goes into a big IV in your vein. And it seems very simple and a very attractive treatment, because you put an IV in, you start putting the mixture in, and it seems pretty quick, pretty simple, pretty easy to administer. But two problems with that. One is it's incredibly expensive for you, for your insurer, for the government, whoever's footing the bill there. It's incredibly expensive. And probably more importantly is that there is a very, very high infectious complication risk of that. And so we don't like to use it. We like to use it in a limited fashion. And personally, I try and limit my use of it to no more than a couple of weeks because of the infectious risk, and particularly yeast infection, something called Candida. So if we can't let you eat by mouth, and we don't want to put it in an IV, what's left? And this is the feeding tube treatment. You may be familiar with that. Enteral access, sometimes people call it. But we're essentially trying to trick your pancreas into still feeding you, but sneaking it by where the pancreas sits in the top part of the intestine. And so that's a very cheap alternative. There are really no problems with infections from that. And it actually is pretty good evidence to say that it actually, on the opposite side, actually helps to prevent infections. Sometimes the gut can get a little bit leaky with pancreatitis, and by keeping food going through the gut, you prevent that leakiness from developing. These sometimes can be put in just at the bedside. Sometimes we have radiology doctors using X-ray, put them down further. Sometimes we put them down with a flexible scope. So a number of different options there. There are really two ways to put them in. One is through the nose, and that obviously is a bit uncomfortable, can have some issues. Or we can put them in directly through the abdominal wall, what's called a jejunal tube, and that's a more long-term solution. So we've seen this slide, and really what we're going to be focusing on next. This is the bile duct, and this is the pancreas duct here. Pancreas. And I talked about this. If we go northeast, I guess, from here, we get into the stomach. And so, as I said, when the food goes in, this has to go by. If you eat it by mouth, it has to go by your pancreas, and this is what sets up that reflex loop to make the pancreas want to produce juice. So a couple things that we can offer from an endoscopy standpoint. You hear the terms, you probably have heard the terms ERCP. Won't bother you with what that stands for, but essentially it's what we are able to offer using the endoscope here, treating problems with the pancreas and bile ducts. So if we go back to our picture, what we're going to be looking at in these x-rays is a stricture here. This is the bile duct. This goes through the pancreatic head, or sometimes behind it. And if you can imagine there's inflammation here, then that inflammation or scar tissue is going to squeeze and put pressure on the bile duct. Very stereotypical stricture that you could see from chronic pancreatitis here. And so we can treat that or actually, let me go back. Why this is important, in of itself, not a big deal, but why it's important is that people can develop jaundice, yellowing, yellow skin, yellow eyes, and some people really could care less what color they are. It's the itching that is really the incredibly uncomfortable thing, and really itching like there's no tomorrow. Infection is another potential risk of the blockage there. Something called cholangitis is the medical term for that. If the duct is blocked long enough, you actually can get liver failure, cirrhosis from that. It's also important. And so for all those reasons, it's necessary to relieve the blockage. There's a couple of different ways. Plastic stents, which look sort of like this, that we can put in and essentially put a bridge across this such that one end of the stent is here, where and this goes to the liver, and one end of the stent is here in the intestines, so that we can bypass this narrowed area, get the bile where it needs to be, and improve the symptoms. And they're unlike the heart doctors that have fairly permanent stents. Our stents are impermanent, and the plastic stents, on average, last about 3 or 4 months. And so the patient can expect, while we're treating this stricture, to have, on average, about 4 ERCPs over the course of a year in order to treat that stricture. We do have metal stents, like what the cardiologist would put in a heart. That's usually what people are most familiar with stents, a heart stent. And those are bigger, and so they work faster. They probably stay open longer. And one of the things that we actually have just started a study here with a number of other centers around the country, looking at how does that translate into anything better for the patient. Theoretically, maybe you do 1 ERCP to put the stent in, you do a second ERCP to pull it out, and rather than 4 stents over the course of 4 ERCPs over the course of a year, the person only has 2 procedures. Good idea. We're not sure if that works yet, but we're studying that. This is what a metal stent would look like. So we've talked about this. Now let's talk about the pancreas. So what can go wrong with the pancreatic duct in chronic pancreatitis? Stones, strictures. We've talked about the sphincter of Oddi. This is a little muscle that controls the flow, sort of a valve here. It's a muscle that can control the flow from the bile duct and the pancreas duct. And so sphincter of Oddi dysfunction is something that we come across quite frequently in patients with any pancreatic disease, acute pancreatitis, chronic pancreatitis. And you see why here about a quarter of patients with SOD will at some point either go on to develop chronic pancreatitis or have chronic pancreatitis at the outset. And if you flip that around, about 90% of patients with chronic pancreatitis will have sphincter of Oddi dysfunction. So those two very, very frequently run hand in hand. Just bring this up just because you may have heard the term, you may have had family members or know someone that's been referred for sphincter of Oddi manometry. That's how we scientifically measure whether that muscle that we just talked about, that muscle is defective or not. And this is a picture of what the catheter would look like that we use to measure that. Pancreatic duct stones. I'm not sure how well this comes across on the screen, but just a pancreas that actually is just encasted with stones. This is a patient I think that Dr. Adams and I shared, and he was nice enough to send me this picture when they came out that essentially looks like a pancreatic duct. And this is all essentially like little chunks of concrete, little pieces of concrete that really fill the pancreatic duct. You can imagine not a lot of place where the juice starts out here in the tail of the pancreas, and this big flood of juice wants to come in this direction to get in the intestines. Not a lot of room for that juice to flow through. And not for this patient, but for some patients, something that if you personally or you've had family members that have had kidney stones, this is something that we have begun to use maybe 5-6 years ago for difficult pancreatic duct stones. Not everybody's a candidate for this, but we essentially pulverize them or shock the stones into submission, pulverize them into a fine dust, so that then they can be passed out of the pancreas duct into the intestines and on. And this is just an example of this. You see, and these are the best candidates. Again, the one I showed you where the stones are all over the place are not good. But if you have one big focal stone, one big stone, then it could be the right situation to use this. And you see here, this is a big stone on an x-ray. This is the pancreas duct. And after 2 or 3 sessions of ESWL, of the shock wave I just mentioned, stone's gone. And this is just to show we looked at a stricture, a tight area of the bile duct a moment ago. This is what a stricture of the pancreas duct would look like, very typical stricture that you might see with chronic pancreatitis. And sometimes we stent these to improve symptoms. Very commonly, the duct above here is big, so big that surgery is the more appropriate thing to do, and we'll probably touch on the surgical treatments of that in a moment. But these are the sort of things that we sometimes can treat endoscopically. Questions, comments?